But in terms, we're going to go over a bunch of different fractures. Hip fractures, make sure you get a pelvis x-ray. If you're working someplace where they don't automatically give it to you, make sure you get it, because that's like a total freebie to give you your comparison view, to make sure you know what's normal. Hips we're famous for not seeing them on plain films. Like I said, femoral neck fractures in younger patients are time dependent, their risk for AVN. My computer at home, my keyboard, I was gradually losing all my use. I started losing my I's, then my K's, then I noticed H's this morning, so I haven't had a chance to go get it replaced. So you may miss some letters missing. What's next? I don't know. Okay. Meninder went over the hip dislocation, and as he mentioned also, X-rays may miss anterior dislocations, though most common hip dislocations, the opposite of a shoulder, most common shoulder dislocations anterior, most common hip dislocation is posterior. Okay, looking at hip, there are a lot of subtle things you got to look at. You got to look at this line on, at the femoral neck. Really look for whether there's any discontinuity. It may be really subtle, so you really got to blow it up and take a look at that. But there are other things to look for as well. And you want to look at the trabeculum. If there's a break in the trabeculum, that could be the sign. And if there's a sclerosis, like some opacity in the density of the bone there, that can be a very subtle finding of a fracture. Okay, so I just want to talk once again how important it is to make the distinction between, make an early diagnosis on a femoral neck fracture non-displaced, because this is the treatment. It's just putting a few nails in or screws in there. Whereas if it becomes displaced, for any amount of time, it's going to need, this is like an older patient, they're going to get a total hip replacement. And, when you look at femoral necks versus intertrochanteric, there's a poor blood supply to the femoral neck. Intertrochanteric, which we see all the time in elderly patients, they have a great blood supply, they heal well, they can have extensive bleeding, and they don't require replacement of the femoral head or hip. So they actually do pretty well. Femoral necks are where you have your problem. In the elderly, we're not in a big rush because generally they're going to get a hip replacement. But in a younger patient, that's a patient you really want to save them. That very invasive. And especially, who knows how long that hip's going to last. So you really want to avoid that in a younger patient. In a young patient, a femoral neck generally indicates a major force. They have a high rate of non-union, so it's important to make that diagnosis. In an older patient, it's much less traumatic. They generally are not going to have associated injuries, and they're going to, but you still, even in them, you want to prevent that non-displaced fracture from becoming displaced. So you want to make that diagnosis early so that they can avoid having that hip replacement. This is a case where you can see this patient has a number of pelvic fractures, but you don't actually see, and the hip looks okay. Then you get a CT, and you see, here's the acetabulum, and the hip is actually out of it. So just remember, if you're not sure what's going on, maybe get a lateral x-ray or go to CT, because you can miss anterior hip dislocations. Now we're just moving on to the knee, and I just want when a patient presents with knee pain with normal x-ray, what are the important things you don't want to miss? And there are a list of 7 or 8 things. So just give me any things that come to mind.
Dislocation.
Right, and that is the most important thing. That is my greatest fear, is missing, a spontaneously reduced hip dislocation, because that even though it's spontaneously reduced, they are at the same risk for having a vascular injury to the popliteal artery and having to get their leg amputated as if it was not reduced. So that is something you got to think about. The patient says, I felt a pop, it's very swollen in their knee. You may want to think about that. Okay, anything else? Tibial plateau. Oftentimes, it's not going to be on your x-ray. It may be there, but there may be some subtle findings which we're going to go over. Okay, so tibial plateau, anything else? What about all the ligamentous injuries? There are a million ligamentous injuries. And so once again, we're going to go over this, but you really got to make sure they can lift their foot off the table, because that indicates that they're patella tendon, their patella, and their quadriceps tendon are all intact if they can lift that up. Very simple thing, very important to examine. It takes 2 seconds. And then all, ACL, MCL, all those other things. Oh, and the one other thing which we mentioned is,
fracture.
Sorry?
Like if they fracture their hip.
Yeah, exactly. That's what I'm thinking. And that's key. So quadriceps, we mentioned this, hip injury with referred pain. There's this locked knee thing where they're not able to fully extend their knee. It's important to find that because if you don't make that diagnosis, you can have permanent disability as a result of that. Septic knee if there wasn't any trauma, compartment syndrome, all these other ligamentous tears.
What causes the locked knee? I feel that's usually like a meniscal tear.
Yeah, I know. Though it can happen, what's actually causing it, I've actually remember seeing patients that unlocking their knee, and they thought that it's a meniscus tear. So, but you can see with an MCL, an ACL, whatever, and I gather they have another injury along with it. So the mechanisms of injury can help tell you, direct blow, patella, sudden deceleration and turning without actually contacting anyone is a classic presentation for ACL, twisting, meniscus, so important to get that history. When you examine the patient, you want to really make them comfortable, having them lie supine. If you really want a good knee exam, place a pillow underneath their distal femur. And always examine medial and lateral. A lot of times tibial plateaus may have lateral tenderness. And then there's the Lachman test. I don't do any of these oftentimes because they're so swollen, it's really hard to get a good exam. But this is probably the best way. Have the knee flex at 30 degrees. You have one hand stabilizing the femur and the other hand pulling. It's like an anterior drawer. Pull the tibia forward and assess the amount of displacement. A lot of times I think the patient's not going to let you do that. Knee extensor injuries. Like I mentioned this, but this is missed 50% of the time. So a simple test, just asking to raise their foot off the stretcher would find that. Quadriceps is the older, over 40, and the patella tendon rupture, underneath, that's the younger patient. So you can sometimes see a divot, where the tendon is ruptured, either inferior or superior, depending on which is ruptured. If they can't do it, then they got a problem. If they can do it, but you suspect they're compensating, you can have them sit on the edge of the stretcher, and then apparently that will eliminate any problem and, by having them set up and see if they can lift their leg up. Okay, and then, you can look at these x-rays. There's a classic patella alta, patella baja, but you may not see it on the x-ray. So don't rely on this. But, here they're actually pointing out, you can feel a divot here, and here, you have the normal patella on the right, you have the high-riding patella, which is unlike the high-riding prostate, like this is just free-form thought association here. Which no one, I have to ask, has anyone ever felt the high-riding patella? Prostate. But unlike that, actually high-riding patella, I have actually seen this. Okay. Okay. These knee extensors, there's no question they do need a knee immobilizer. There's going to be this whole question whether you should be doing it for ACL or others. Like some people will say put it on for a few days, don't keep it on too long. But definitely for these extensor mechanisms, this is where immobilizers are great. It really allows them to get around. Okay. And occult knee injuries, ACL. These are classic. They don't bang into anyone. They have immediate swelling. They have to be carried off the field. They can't walk on their own. A lot of these other injuries, they're able to walk off. But ACL, where they get immediate swelling and they really generally, it's just sudden stop and turning. They feel a pop oftentimes. They may have, there's certain findings you're going to find on an x-ray, especially in a kid, tibial spine fractures or Segond. And when you send them home, it's, but always do a straight leg test on them too. Once again, they should be able to lift their foot off the stretcher if they have their ACL, okay, because their extensor mechanism is still intact.
So Dr. Gruber, someone has pain over their patella, they can't extend their knee. I mean, what? So you just put them in a knee immobilizer and say you need to follow up with ortho tomorrow. I mean, like,
But they can't extend their knee. Okay, so we get X-rays, and you don't feel any divot, in there where their quads tendon is or their patella tendon, but they can't lift it. I mean, there are two things. You get an X-ray, you don't see a high riding patella. This is the one indication where you can get an ultrasound, and that is really the only indication for knee injury for ultrasound, because it can detect very easily, and I have actually sent them upstairs for this, to detect a rupture of the tendon. So you can make the diagnosis that way as well. But honestly, if you didn't have that, sure, I'd put them in an immobilizer. If they were not able to extend it, and I'd say cannot rule out extensor, injury. This is you can't see it here, but it's off the lateral distal femur. There's a little vertical fracture there. That's very typical of an ACL. If you see that, you really got to be concerned about that. And then tibial spine injury. These are the spines right here, and the ACL attaches over there. So if there's a fracture there, you oftentimes see that in kids. You can get a special tunnel view, which shows you beautifully the spines. So if you see that in a kid, really think about an ACL. Okay, patella fractures. You can get also the skyline or sunrise view. That's a sunrise view. Patella dislocation. This is pretty obvious. It's hard to miss. They're going to come out. It's sticking out. But sometimes they may feel a pop in the knee. You're saying, oh, could this be a knee dislocation? It's more likely to be a patella dislocation. And then there's this apprehension test if if it did spontaneously reduce. So if with lateral movement of the patella, because they've injured the medial ligament, so when you try and push it laterally, they're going to get very upset. That's typical of a patella dislocation. And the one other thing is when you reduce it, this is like when you reduce ankles or subtalar, which we're going to hopefully have time to get into. You want to flex the hip and and you want to extend the knee. And oftentimes just doing that will come in spontaneously. But then it's out laterally, so you're going to be pushing medially, but you also want to push posteriorly. So you're lifting up the medial aspect of the patella, so it's going to override in easily. So you want to push it medially, but also posteriorly, and it should slip in. This is a really easy thing to do, but at the same time, as with everything in medicine, you can run into problems. Like I had one, we could not get it in. The chief ortho came down. Went through the whole hierarchy of ortho, and finally it was being hung up on something, and we managed to get it in. But it's generally something you can easily do. Flex a hip, extend the knee. Okay. That can happen with MCL. Just make sure you see if they can't fully extend. Don't blow that off. It can be important. Just report that and have them follow up. Tibial plateau, as we mentioned, can be very subtle. In an elderly patient, a young patient, it's a high velocity injury, and it's very subtle findings on the X-ray. Normally, the lateral condyle is higher than the medial. If it's lower, suspect a tibial plateau. And then other things to look at is that when you draw a line through the lateral part of the distal femur, it should line up with the condyles of the tibia. Okay, and over here, when you draw the line down, if it comes out, the tibia comes out further laterally, then that's an indication you may have a fracture. So the 28-year-old woman, knee pain after falling while skiing. It's kind of hard to see this here, but over here, if you draw a line down, the tibia is sticking out further. So that raises a question. But also, you can't see this on this. There's also sclerosis. There's opacity right over here. Okay, and when you see disruption of the trabeculum or just opacity, which is not elsewhere, always think about that as being a fracture, or it could also be a stress fracture. But you'll see this in the for tibial plateau. And here, when they actually did CT, you can see there's actually a big fracture there. So X-rays, you can get oblique views, but if they had a big injury, they have a lot of swelling, I'd probably get a CAT scan. It's important to make this diagnosis. Okay, What if patient with tibial plateau has significant pain when you move their big toe up and down, and they have a lot of swelling? What do you think could be going on? Okay, so because you have all these different compartments, right, in your leg, and what are the findings for compartment syndrome? Pain out of portion findings. So maybe they're not doing that, but it's also severe pain, like if you plantar flex or dorsiflex a foot, that's a classic finding for compartment syndrome, where they have any range of motion of their foot is an indication of a compartment syndrome in their lower leg. And if they have their primary injuries to the knee, but severe injury when they move their foot or their toe, I just think about their compartment pressures. Okay, and this increased density of the bone, this is not going to show up too much on these over here because of the lighting, but you can see it on the hip, you can see it in the calcaneus and the tibial plateau. Here, when you're looking at these two, there is increased bone density over here. You guys can't see this, I take it, right? Because I have a hard time seeing it over here. But there is increased density. The trabeculum's disrupted. I just want you to have this in your repertoire when you're looking at x-rays to think about this. Look at the trabeculum, look for opacities where they're not supposed to be, and that could be a subtle finding of a fracture.